a patient's perspective. You'll receive 2 hours of COPE-approved live credit for attending tonight's program. And we will post those hours for you electronically to the ARVO site using the OE tracker number you use for your registration and login. We'll additionally post the hours to the Texas boards for all those Texas attendees this evening. Please remember, if you've got questions for the speakers, post those questions to the Q&A box at the bottom of your screen. If you have questions for the moderator in regard to technical aspects of tonight's webinar or the certificates or certification of your hours, please post those in the chat box. With that, I'd like to welcome Dr. Jeff Gerson, who is the Optometric Medical Director of Macular Degeneration Association. Turn over the program to you.
All right. Well, thank you, Stuart. And thank you to everybody that is logged on for our 2-hour educational event tonight. I really want to thank everyone for coming. Just real quickly, wanted to tell you very briefly about the Macular Degeneration Association. It was started back in 2007 by Mr. Larry Hoffenheimer, who started because he saw his mother suffering with macular degeneration and wanted there to be more resources for her and people like her. And so since then, the Macular Degeneration Association has strived to provide information and materials for those with and those caring for macular degeneration, historically by doing in-person events. But just like many other things over the last year, we've transitioned to doing virtual events for patients. You can direct your patients to our website, where we'll have about 35 more scheduled, at least over the rest of 2021. The other thing that I'll tell you about is our program Centers of Excellence. And it's something that you as an optometrist can apply for and become recognized on our website as a source for AMD care for potential patients. So I would encourage you to go to the website, macularhope.org, and then look up Centers of Excellence, and hopefully you'll look at the criteria and apply and join us there. Then the other thing that we've transitioned into doing over the last 12 months is providing continuing education for all of us, for optometrists. And I believe this is our 4th program, and each one of our programs has had about 1,000 people. So we're glad to have been able to have reached so many ODs, and really excited for tonight's program, which will be a little bit different than what I think you're accustomed to seeing traditionally for continuing education. So really, without any further ado, I want to hand the program over to my good friend and colleague, Leo Sims, who many of you probably know. Leo had a long career at University of Alabama, Birmingham School of Optometry, where he was then named Professor Emeritus. Has been a key opinion leader in the areas of macular degeneration, glaucoma, and other conditions. And if you've had the opportunity to hear Leo speak, you know why we're in for a treat, because he's so well informed and does such a great job. Shortly after Leo starts, we'll be joined by a retina specialist, Dr. Rathod from Orange County, and we'll have some unique things with him interviewing a patient and showing showing a patient getting intravitreal injection, and just showing AMD from our patient's perspective. So again, I want to thank everyone for attending. Thank No Tall Vision for giving an unrestricted educational grant for this to happen. Please visit our website, macularhope.org. And with that, I'd like to turn the program over to my good friend and esteemed colleague, Dr. Leo Sims.
Thank you very much, Jeff. It's very nice to be here. There we go. And I'd like to add my welcome to all of you in attendance as well. I think, as Jeff described, this is a unique program, and I hope it's as exciting for you as we are to present it. So what I'd like to start off with is just a little bit of background on age-related macular degeneration. And you can see the title there, The Patient Experience with AMD. And certainly we want to emphasize that. Dr. Rathod has an interview with a patient, which is, I think, very, very enlightening, and we can look forward to that. But obligatory disclosures here for starters. And I just thought I'd start with a couple of recent items from something that comes across my email called Ophthalmology Advisor. And these are both within the last month. And the one in the panel on your left, I think, is very significant. Over 60% of wet AMD fellow eyes lose too much vision, even with frequent treatment visits. You saw in the introduction with Susan talking about her experience that she was fortunate enough to be monitored and her first eye was caught. But often, because of the asymmetry and because patients don't often check each eye separately, that can sometimes get lost. And then the other item that I thought was of significance, because my mother suffered from glaucoma and was treated for 55 years of her life, that glaucoma is underdiagnosed in patients with wet AMD. So we don't want to overlook the optic nerve when we're concentrating on the macula. So just a little bit of clinical wisdom there. But I thought I'd include two other things. And that really emphasizes something that Susan talked about, and I'm sure Dr. Rathod is going to be stressing, and that is delay in diagnosis. So one of the things that we want to do is with a glaucoma patient, see it at the earliest stage, and similarly with macular degeneration patients. So that's going to be one of the keystones of care for our patients. And then the other pinnacle really of patient management is patient education. And I think it's very significant that, again, this little article here about more patient education needed for the proper use of aspirin and statins in patients. So we really need to take the time to educate our patients with regard to early diagnosis as well as continued managing care. I want to spend just a little bit of time here talking about AMD staging and ask you as an audience if this is something that you apply in your practices. And this is a staging scheme that was based on the original ARED study and then updated a little bit with the passage of time. But it goes something like this. Category 1 is very no or small drusen. And if you look at the upper panel there, you can see that that fundus looks really quite pristine. So it might be difficult for us to appreciate very small drusen on casual examination or just cursory review of fundus photography. But these patients are at fairly low risk of progression to age-related wet macular degeneration in 5 years. And excuse me, trying to do two things at once here. Category 2 is intermediate drusen. And this is something that I think is very significant because it's based on the size of the drusen. And even a single drusen that is greater than 125 microns does put the patient on a potential trajectory for vision loss. So we want to be very cognizant of not only drusen presence, but also drusen size. And one of the things that I've come to measure since this scheme was introduced is this value or this yardstick of 125 microns. 125 microns is roughly the width of a vein where it crosses the disc margin. So we can use that as an internal marker and then go back and say, well, if the drusen is very small, if it's less than half a vein width, then we're looking at a very small drusen. So we want to make a distinction between large and intermediate drusen. And of course, large drusen are those that are greater than 125 microns. And of course, the patients whom we don't want to see are those in the more advanced categories here. But a couple of things about AREDs, and this is something that when I lecture with Jeff, he always likes to point out, and I think it's quite significant, that in order to be included in the ARED study, you had to be at least 50 years of age for starters, and you had to have at least moderate age-related macular degeneration. So it was not naive patients, it was not patients who had advanced disease, but patients with moderate AMD with regard to their clinical staging. So let's take a look at one of my patients from UAB Eye Care. His acuity here is 20/60. You can see that he's got fairly high risk, just focusing on the fundus photograph initially, the color fundus photograph. And you can see that he's got some pretty distinct pigmentary changes. He's got some geographic atrophy. The individual drusen don't really show up well because they've kind of coalesced in large part to geographic atrophy. But he had a 2-line drop in his visual acuity from the previous visit, which was delayed about 4 months from his scheduled visit. And we can see from the OCT that he's got some choroidal neovascularization. So that's one thing that's responsible for his precipitous drop in vision over the next couple of months. And this is his fellow eye. And what we can see here is that he's got some large drusen as well as pigmentary changes. So he's essentially got 4 of the elements that would put him in a very high risk category for a very significant trajectory toward vision loss over the next 5 years. So what we want to look for carefully on clinical examination as well as review of fundus photography is what our patients are exhibiting with regard to drusen size, and pigmentary changes. So we can score a point for every large druse, a point for pigmentary abnormalities, and we do that with each eye and then sum those scores. And with, as in this case, the patient's score of 4, we've got a situation where his likelihood of progression is quite significant. To follow up on his trajectory, he was administered an anti-VEGF agent in the right eye where we saw the choroidal neovascularization previously. He subsequently needed about a half dozen anti-VEGF injections in each eye and unfortunately passed away with about 20/60 visual acuity in each eye. So we were able to maintain over the course of about 3 or 4 years his baseline level of visual acuity. There are a few other additional risk factors that we can add to our profile as we look at patients with regard to risk, aside from our clinical findings and their physical characteristics from fundus photography and clinical examination. And not surprisingly, at the top of the list there, patients over the age of 85 and those with a family history of age-related macular degeneration, but also hyperopia. And there are a number of speculations as to why that may be the case, and you can choose your own theory on that. Cataract surgery, as you're probably aware, is somewhat controversial with regard to accelerating the changes in age-related macular degeneration or placing the patient at a risk for a faster trajectory. And surprisingly, and understanding that this study was conducted in Europe, North African ancestry versus Caucasian actually put the patient at a higher risk. Not surprisingly, and one of the reasons I italicized it here, is a history of atherosclerosis. So when we see a patient with elevated cholesterol, or perhaps a patient who is medicated for elevated cholesterol, we should begin thinking that this is one of the tangential elements that might accelerate the patient's risk. And something that is near and dear to my heart, and that is a history of smoking. Smoking perhaps should be at the top of the list overall, but we're looking at just results from this particular study. But I think it's significant that even many countries in Europe now admit that a history of smoking can contribute to age-related macular degeneration. And this is one of the things that I get on my soapbox about, because my father was a smoker, and to his credit, he discouraged his firstborn from smoking. So something significant there. And then along with atherosclerosis, patients who have a history of myocardial infarction, perhaps again, not surprisingly, place themselves at slightly greater risk for age-related macular degeneration. So one of the questions that I like to ask is, how well are we doing as a profession, as an ophthalmic profession, at diagnosing age-related macular degeneration? And some of my former colleagues at UAB had the same question. So what they did was they took a look at a cohort of patients whom they had recruited for the Alabama age-related macular degeneration study, the so-called All-Star study. You may have seen publications from that. And what they determined was that about a quarter of so-called normal patients, in other words, patients in ophthalmic practices, both optometry and ophthalmology practices, had findings that were consistent with early age-related macular degeneration, but were not reported by the examining clinician. So I think it's significant that while it may be easy to overlook some of the early changes, that they can really be quite significant. And you're probably wondering, well, how did these patients come to light as having age-related macular degeneration changes? And it's from the photographic evidence that was provided by these same practitioners and was evaluated by a reading center, so a standardized reading center for the color fundus photography. As a subset here, about a third of patients with AMD had large drusen. So if you remember back to our staging, that would place patients in a category 3. So that's really quite significant and fairly far advanced with regard to the trajectory of age-related macular degeneration. And as I mentioned, participants in this study were both ophthalmologists and optometrists, and the diagnosis was missed roughly equally. The other thing that's significant about this paper is it was one of the top 5 read papers in ophthalmology in 2018. So quite significant that this is an issue that we as optometrists, as well as examining ophthalmologists, can turn the tide on. One of the things that was determined with regard to an early indicator of age-related macular degeneration is dark adaptation. And while not everybody has instrumentation in the office to quantitate dark adaptation, it does represent the earliest biomarker. And this is an instrument that was developed at UAB by Dr. Greg Jackson, and it has demonstrated in this all-star study that patients with impaired dark adaptation, identification of subclinical AMD, was present 3 years before it was visible with imaging, including OCT. So I think it's significant that if we don't have the instrumentation, we might be able to get an index of patients' performance simply by asking a couple of simple questions like, well, how do you do in the dark? How do you do in familiar situations in the dark? Have you given up driving at night? Do you have trouble if you go from a bright to a dim environment? Do you find yourself needing more light as you get older, which might just be consistent with aging, but it might be a prompt for us to investigate a little more carefully what we might expect in our clinical examination, and looking more carefully at that. So the early diagnosis of AMD, I have a series of questions here, and Jeff, maybe if I could ask you to chime in here. The Amsler grid is about 75 years old. So is it outdated? Is it something that we should still recommend for our patients? Should we rely on symptom reporting? I know there's some variations of the Amsler grid. You look at a straight edge, you look at a doorway, you look at mullions in a window, et cetera, et cetera. And then what about the penetration of dark adaptation testing? Is that something that we see becoming more useful in the future? And a similar question, what about home monitoring, as we saw from Susan's case in the beginning?
Yeah. So, is an Amsler grid outdated? I think that's a good question. What I would say is an Amsler grid is sometimes better than nothing. And the reason I say only sometimes, because if it's not done correctly, then it may be worse than nothing. And so I think very careful instructions are really important for an Amsler grid or whatever other type of home monitoring somebody's doing. But I think it's really important for our patients, especially with intermediate or more advanced dry macular degeneration, to be monitoring their vision somehow at home. We saw that video of the 4C home, and I actually employ that with quite a few of my patients with intermediate dry AMD, only because it's so much more sensitive and really specific than an Amsler grid or any other way of measuring for any subtle change. But I think it's, what can be dangerous though is to rely on patients for symptom reporting for them to tell us that their vision gets blurry. Because by the time somebody's telling you that their vision's blurry, it may be too late.
Sorry, I got a little ahead of myself there.
That's
I think,
okay.
I think, as I mentioned earlier, one of the pillars for good patient management is certainly patient education, and I think you've really reinforced that. But I can tell you this: that a lot of times when I would give a patient a paper Amsler grid to take home, the first thing they do is fold it in half and put it in their pocket.
Right.
So I became disenchanted with it quite some time ago. So symptoms might be useful, but I think probably monocular testing is something that we should really stress to our patients. And a number of years ago, the National Eye Institute put out something called audacious goals, and they wanted everybody to kind of give their input as to something that would be very useful for preserving vision in the future. And there was a lot of stuff about stem cell research and this and that, and retinal implantation and so forth. And I said, look, just put the big E on the television screen at 8 o'clock every night. Tell people to stand at the other side of the room, cover one eye, cover the other eye. If it looks different, go see somebody. And maybe something just a comparison between the eyes might catch a lot of patients with asymmetrical change and get that first eye treated, and then save that second eye.
Yeah, I think that's great advice. Just checking vision. I guess the only one I didn't answer on here with you is the role for dark adaptation testing. And I think that's a real interesting one because, that's oftentimes for people that aren't aware that they have macular degeneration. And as you pointed out, studies show that eye care practices oftentimes miss AMD when it's there and we're looking for it. So I think it's a great way to pick up macular degeneration when it would be otherwise missed, or to be able to follow it over time to see as it's changing, just as maybe we would for someone with glaucoma. We follow visual fields. Leo, there's a question for you here that I think we'll probably get to in a little bit. Can you point out what you see in the OCT to determine choroidal neovascular membrane? So my guess is we'll get to that moving forward.
I'm going to go back to the case that I presented because it's quite subtle. But if we look at the retinal laminations, we can see that the inner retina here in the horizontal cross section looks fairly well intact. We do have some lumpiness here at the level of the retinal pigment epithelium. So this would be the first indication that there is going to be some subretinal invasion through the retinal pigment epithelium. And then we can look at a couple of other things. The topography here shows that we've got some thickening in a sector that corresponds with that area just to the temporal side of the macula. And then if we go down to the RPE slab, we can see that there's some irregularity there that in the slab corresponds with this particular cut. So we don't want to see an irregularity of the retinal pigment epithelium. We remember from all of our textbooks and the histology that we learned in optometry school that is a very uniform single cell layer. So any irregularity of that would suggest that we've got some invasion from the choroid in terms of choroidal neovascularization.
Leo, and one other quick question that we had posed to us is in regards to proactive testing, could you discuss the pros and cons of macular pigment optical density versus dark adaptation testing?
Okay, that's a tough question. I'm not sure that anybody's done a comparison of that, excuse me, but we attempted to do just that, to find what correlation there might be between impaired dark adaptation and some sort of deficit in macular pigment optical density. And we were unable to make any sort of correlation with that. And if you think about it anatomically, macular pigment optical density is going to be measured in the inner retina, and dark adaptation is going to be concerned more with photoreceptors and outer retina. So finding a one-to-one correlation there might not be expected, even though going into the study, we had hoped to find that. We were unable to do that. That's some unpublished results.
You know, the one other comment I would make is that macular pigment is more of a risk factor, where dark adaptation is more diagnostic of.
Okay, sounds good. So Jeff mentioned that I practiced in the state of Alabama for a number of years, 37 to be exact. And if you've ever watched an Alabama football game, even though Nick Saban here is ahead 37-7 at the half, his first comment is, "We've got to do a better job." So if we think about how we assess early age-related macular degeneration, how we might query our patients, what sort of history we take with regard to our patients, earlier diagnosis is going to be the key. And I think we can do a better job here. So with that, I'm going to turn it over to Dr. Rajiv Rathod, who is a graduate of Stanford University. He then proceeded to Nashville, Tennessee, and did a combined program in medicine and received an MBA. Did his ophthalmology residency at Washington University, where he was chief resident and earned a number of awards. Continued his way toward the West Coast again with a fellowship at the Illinois Eye and Ear Institute, where he was voted the top fellow. He has numerous publications and has participated in many clinical trials. So with that, I will turn it over to Dr. Rathod.
Sorry, I was on mute. All right, hello, greetings everyone. Thank you for your time this evening. And I believe we're gonna start by going to interview a patient who is gracious enough to offer his time and opinion on his experience with macular degeneration and getting treatment for macular degeneration. Hello, everyone. And we have Mr. Gamble here, who has graciously agreed to be interviewed regarding his experience with macular degeneration and receiving treatments with intravitreal injections. Mr. Gamble, thank you again for your time, and thank you for sharing your experience. We appreciate your input and participating and helping folks to understand what it's like to have macular degeneration and get treatment for macular degeneration with injections in the eye. So let me ask you, what was your first thought when you were first told that you were going to need injections in your eyes for macular degeneration?
Well, I would be lying if I said that I didn't freak me out because, you know, I'm very sensitive in the eyes anyway, but I've been going to ophthalmologists every year, and I've also been going to OC Retina for quite a while, and used to having people dilate my eyes and all that. But that's so different, and having pictures taken and that, but it's so different of having an injection in my eye. I have a problem, and it still freaks me out, is when you check for glaucoma to touch my eye with that. And I thought, what in the world happens when they stick a needle in your eye? but I trust you, doctor, and I've trusted all of your medical assistants, and I've met about 6 or 7 of them. And so I trusted them. And so it calms me down a lot to know that you guys care for me.
So I'll just say that you're not alone in having those thoughts and fears when when someone tells you that you're going to get an injection in the eye. Obviously, that first sounds like a scary prospect. Certainly, a lot of people are sensitive with the eyes to begin with, and then having a needle inserted into the eye directly often catches folks off guard. So that is a very common reaction and common viewpoint on initially being told about needing to get an injection. So now, the first time you received an injection, do you remember sort of your feeling or your thoughts and what it was like? And can you kind of give us a description from your perspective of what it was like to get the injection the first time?
Well, it started out very similar to the rest, where they put the drops in to dilate my eyes. And then they started a new procedure where they would put a smear or something on my eyeball to start deadening it. The first one seemed more liquidy, and then it got a little thicker as it went through. And then they took a Q-tip and held it on my eye. I knew at that point it was going to be different, but my eyes become deadened at that point. And so that when I went into the other room, they still had a couple of procedures that they used to deaden your eye. And from there on, it went very smoothly.
And what Mr. Gamble is describing is and there are different ways of numbing up the eye, but some common ways of numbing up the eye prior to injection are using eye drops and gels and Q-tips to help to anesthetize or numb the surface of the eye, so that when the injection itself is given, there's really no pain involved. Rather, you might feel a little pressure sensation, but generally the injection itself is not painful. And Mr. Gamble, can you attest to that? That after your eye was numbed up and you had the injection, you were surprised that you didn't feel as much as you might have thought you would from getting injected.
No, it was just a little pinprick, and then I see the injected, and I see what I call a jellyfish. It looks like a jellyfish shows up in my eye, but it was painless, basically.
And I think that's a common reaction. Often I give folks their first injection, and their first reaction is, that was it? You already did it? As if to say, oh, I didn't even know you had already given the injection. And what Mr. Gamble described is that you can actually sometimes see the liquid, which is the fluid of the medicine that's given as an injection as it enters into the eye. And sometimes it looks like a jellyfish, or some people say like an amoeba, little cloud. And that usually clears up after a few minutes. But you can actually see the fluid from the injection going into the eye. And that's really the only evidence or sensation that people know that they've actually gotten the injection, is that they can actually see the fluid. But outside of that, they may feel just a tiny little pressure, or as you said, like a little pinch. And I generally will warn people by saying little pinch, to tell them ahead of time that I'm about to give the injection, just so they know it's coming. But to say that it's actually going to be minimal amount of sensation that you feel. So now you've been getting injections for several years, and you're kind of used to it. You're a veteran with the injection process, and everyone comes up with sort of routines, and a lot of folks have some anxiety over getting the injection the night before. So is there anything you do to prepare ahead of time before you get an injection?
Not really. I feel very comfortable coming into the office and seeing the people that I've met before and what they've done. And I get sort of in a routine. As long as that routine happens, and the deadening of my eye, and then looking down and left or right or whichever eye, and I get used to that. and it's not a big problem. So I just relax and go with the flow.
And then after the injection, what can you expect, and what are some of the things that you experience or look out for after you get an injection?
Once I get an injection, and my wife usually drives me home, is that within an hour, I normally get a very horrible headache, and it stays with me for quite a while. When it first started, the injections, they were pretty severe, but this last one only lasted about, I don't know, 30 minutes. And then it just sort of immediately just poof, disappears. So hopefully from here on out, that's what will happen. So, but I've always expected to have a headache. And so what I normally do is get an audio book, and I listen to an audio book, and everything comes out okay.
So I think what Mr. Gamble is experiencing sometimes with an injection, the pressure in the eye goes up a little bit, and that can be translated or felt as a headache, which generally lasts for anywhere from 30 minutes to an hour. Not to say that everyone experiences that, but some people do certainly experience that. And sometimes the eye can feel a little irritated afterwards, like a dry sensation or a foreign body sensation, just from the preparation process. So we generally tell folks to use lubricating drops afterwards if it does start to feel irritated. And then of course it is an injection in the eye, so we caution folks to keep the area clean, not to touch the eye with dirty hands, and not to let dirty water run into the eye, just to prevent the possibility of getting an infection in the eye. So that's a very typical after injection experience. So if Mr. Gamble, if somebody were to come to you and say, hey, my doctor told me I need to get injections in my eye, how would you prepare them, or what would you say to them to help them get through that? How would you give them your take on it to say, hey, this isn't something you need to be too worried about?
I said, first of all, is you have to know and have comfort in your doctor and their assistants that they are working for your benefit. And if you don't have that, you're probably in the wrong place to start with. But if you have that, go with it, do what they say, and everything will come out okay.
I like it, the go with the flow kind of mentality. Now, looking at sort of your overall quality of life and life experience, because obviously having to come in sometimes twice a month for injections, because you get it in one in each eye, it can put a toll on your schedule and your quality of life. And for many people, often people are retired, but some people are still working, and you need to come in and make time for appointments. What can you say about the overall effect of having to get these treatments on your quality of your life and your ability to do the things that you normally do and like to do?
Well, as being retired, I pretty well have a pretty flexible schedule that I can work around. That's not a problem. I would love to be able to go in and get both injections in both eyes at one time, rather than spacing them out at a week and a week from that. But other than that, it's not affecting my ability or my life, other than it is having an effect on my ability to drive, because this last time I had to take a form in from the DMV that you guys have checked my eyes and all that, and they've only renewed my license for 2 years. And if it degenerates further, if my left eye degenerates further, then I probably will have to quit driving. So that would have a bigger effect on my life than anything.
Well, we can see that you like to travel. It seems like you're in an exotic
Yes.
place right now, but you're still able to do things like travel and, you know, and obviously times are different right now, but outside of the pandemic concern, you've been able to do sort of all the things that you generally enjoy and like to do in your life.
Yes, it really is. Carol and I have traveled to over 70 countries, and we've been to all 50 states. And so we do a lot of traveling, and we still have a lot of plans to go. And it is not affecting that at all. Even if my left eye becomes worse, it is still not going to affect our ability to travel, because she is a good set of my eyes. We've been married almost 55 years, so it will continue, and it doesn't affect our lifestyle.
Good. Well, good for you. Now you already mentioned that you have your wife Carol drives you to your appointments when you get the injections.
Yes.
And that's not uncommon to have somebody to drive you to the appointments. I will say that there are some folks who feel very comfortable driving after an injection. So it's not to say that you're unable to drive. It's just more of a comfort level after getting the injection.
The big deal is not the injection so much as usually have my eyes dilated, because you also look at them and take photos and that. So it's more the dilation than the injection.
Sure. Yeah. Yeah. So if it's just an injection, then you may still actually be able to.
I could drive. That's not a problem.
Sure. Okay. Okay. Well, is there anything else that you'd like to share with the folks listening regarding your experience with macular degeneration and getting injections?
No, I just wish that there was a way to correct. Like even right now, having a computer close to me,
Looks like we may have hit a little snag at the very end of the video there, Dr. Rathod. If you want to pick up and continue while we try to load the injection video for you.
Of course. So that was a very kind patient, Mr. Gamble, who shared his experience, and we're very thankful that he was able to tell us what it's like to get an injection in the eye. Now we're actually going to see a video of him receiving his injection, his treatment in his eye for macular degeneration. So we'll play that video, and I will describe what's happening as we watch the video. Okay, so you see Mr. Gamble here, and he's in chair, reclined comfortably, and he's already been prepared. So he's received lots of anesthetic on his eye, so drops and gels, as we talked about earlier. And so he's all ready to have his injection. So generally have the patient look away from the approach, so they don't necessarily have to see the needle. I use a little speculum or clamp to hold the eyelids open so that it's more controlled. You don't have to worry about closing the eye suddenly. And then we use some other antiseptics on the surface of the eye to help reduce the risk of infection. And Mr. Gamble is a very good patient. He's sitting there patiently and holding very still. And then again, we come from the opposite side just so that they don't see the needle coming. We measure the exact location of the injection. The injection is given through the sclera, and then the needle is removed, and the cotton tip applicator is used to just hold gentle pressure over the injection site. And that's pretty much it. So it's actually very quick. The injection itself is very quick. Most people are surprised when the injection is given. It's happened so quickly. They said, "Oh, I didn't even know it was going to be done," and it was done. So that's how we generally give our intravitreal injections. And then we rinse the eye out afterwards to help prevent any irritation after. So we'll thank you again to Mr. Gamble for allowing us to show his treatment and his injection.
Okay, I think what we'll do now is have Dr. Sims join back into the program, and I think he's got some questions he'd like to pose to you, Dr. Rathod, that we can answer for the audience. And then as the audience continues to submit questions to us online, as we wrap up some of Dr. Sims' questions, we'll turn back to some of the audience questions that we can resolve as well.
Okay, great.
All right, Dr. Rathod, that was very interesting, both your interview as well as the procedure. With regard to Mr. Gamble, would you describe him as sort of a typical patient in that he had some apprehension or anxiety at first, but then with some experience, he seems to be quite sanguine with the procedure as he has it repeated?
Absolutely. I think most, and it's natural to have some apprehension when you're told that you're going to get an injection. I certainly would if somebody were to tell me that I were going to have a shot into the eye. So I think the typical patient, yes, is apprehensive when they first hear of the prospect of needing treatment in the eye with injections. And then once they experience the process and realize that, it's not painful and they can handle it, they get more comfortable with it. So that's the typical patient. There is the occasional one that even after their 50th injection, they come in and they say, I still have some anxiety and I wasn't able to sleep last night. But that's a rare patient that has that sort of reaction. Most people get comfortable after going through the process. So.
Well, you answered one of my other questions there, and that is, you said that some patients may have as many as 50 injections. What's kind of your record? If we as a referring optometrist were to give some expectation to a patient with regard to course of treatment, duration of treatment, et cetera, what's kind of the number? And maybe it's a time frame, and maybe it's not a number of injections that that would be the outside, the
Sure.
gold medal winner.
Yeah. Well, so when people ask how many injections can I get, the answer technically is as many as you need. So generally an eye can handle as many injections as is necessary. And, of course, everyone's different. For some folks, they actually continue to need treatment throughout the course of their lives, in which case our goal is to try to keep the disease under control as best we can, but minimize the burden of treatment. And we do that by trying to extend the interval between injections. And in doing so, they might not necessarily need it every month, but sometimes 4 times a year, 5 times a year. And that can be, again, done indefinitely. And so many folks need to have injections on an ongoing basis, such as that. There are some situations where the disease activity does settle down and it may not reactivate, in which case we just watch and monitor, and if we see recurrence, then we resume treatment. So that being said, I certainly have folks who have needed treatment in both eyes and who have received over 50 injections in both eyes. And so, adding that up, that's 100 injections, over 100 injections. So, certainly the eye is well able to tolerate getting continued injections such as that. So, again, when folks ask when does this end, I can't always give a good answer, because for some people it doesn't end, and for some people after time things settle down and we can stop giving injections.
That's great. If we could stay with Mr. Gamble for just a minute. One of the things that he mentioned was the headache sensation, which, if I'm not mistaken, he attributed to increased intraocular pressure. What's your typical management strategy for that situation?
Sure, correct. So obviously, when you're injecting fluid into the eye, the intraocular pressure is going to increase. We're injecting a volume of 0.05 milliliters, which is a very small volume. And though the pressure does increase transiently, it generally, in most eyes, is able to auto-regulate fairly quickly and come back down to a normal level within, if not within 30 seconds to a minute, then within several minutes. And for some people, they feel that pressure sensation, even though the pressure has come back down, they feel that as sort of a lingering headache afterwards. And so I think that's what he's describing. I don't think that's necessarily very common. You'll generally feel the pressure sensation and the increase in pressure when the injection is given, and then that generally settles down or improves rather rapidly after the intraocular pressure comes down. So I don't have any other specific management other than for intraocular pressure after giving an injection, other than folks who maybe have a history of persistent elevated intraocular pressure after injection, and sometimes those are narrow angle patients or angle closure glaucoma patients, in which case we will monitor their pressure and if necessary use topical therapy to reduce the pressure. Some folks, and this is also uncommon, but some folks may actually run extremely low blood pressure just as a baseline, in which case their perfusion pressure, ocular perfusion pressure is low, and giving even a small volume of injection, raising the intraocular pressure just slightly, can overcome the perfusion pressure and arterial flow into the eye. And so if someone says, you know, they can't see very well all of a sudden, then we'll look at the optic nerve and see if there's pulsations, try to reduce the pressure more rapidly. And if it seems that it needs to be done more rapidly, then we can actually do an AC paracentesis and remove fluid from the anterior chamber to help reduce the intraocular pressure. But that is rarely needed to be done.
So with Mr. Gamble's procedure there, following that, I mean, it was pretty straightforward. Could you comment just a little bit on the specifics of your anesthesia, and then following his injections, what steps do you take? You obviously don't send him right to the parking lot.
Sure. So the preparation, you know, we use topical anesthetics generally, and that starts with proparacaine or tetracaine to initially just anesthetize the surface of the eye. And then we're very careful about antisepsis, and so we use betadine drops, diluted drops, betadine on the surface, ocular surface. And once those are instilled, then we use a combination of other types of lidocaine, either in the form of gels or liquids that are soaked on cotton tips, and apply those to the site of the injection. And there's you know, 100 different techniques for anesthetizing the eye, but generally do several rounds of drops and gels followed by the Q-tips. And in that setting, or in that situation, we found that you know, 99% of the time the eye is numbed well enough that people really feel very little. So that's the preparation process. And that takes about maybe 15 to 20 minutes or so to get the eye ready and prepared. And then afterwards, we'll rinse the eye out with sterile water just to remove any betadine that might be left on the surface of the eye. And once the eye is well rinsed, which helps to prevent irritation afterwards, then we make sure, you know, the patient is at least able to see, count fingers. And if they are able to count fingers, then we know that there's perfusion to the eye. And then we review the things to look out for afterwards, signs of endophthalmitis, which we'd be most concerned about, which include pain and blurred vision. And we review the instructions afterwards in terms of making sure the eye and the area around the eye stay clean and away from any dirty environments.
And then following the injection, with regard to refraction, what's your typical recommendation for when a patient can have a stable refraction?
So that's a great question, and you know, some of that depends on the disease activity. So if we think that the disease activity itself is stabilized, then depending on the frequency of the injections, I think generally at least a week after an injection is a safe time to have an updated refraction. But if there is ongoing disease activity and the macular degeneration, the subretinal fluid or the choroidal neovascularization is not well controlled, then I certainly advise folks to wait until we have a little bit better control and we know that the disease activity is stabilized before actually updating the refraction. Because obviously if there's fluid under the retina or in the retina, that can affect the refractive outcomes.
And what about your cue for interval of retreatment? Is that more based on fluid or central retinal thickness or visual acuity?
So we use a combination of things to determine the ideal treatment regimen. We are obtaining OCTs at each visit to see if there is fluid in the retina. So that's one of the big factors. Visual acuity plays into it also. Patient symptoms also play into it. So often folks will have symptoms before they're able to we're able to detect any activity on OCT scan or change in visual acuity. They may just notice some mild metamorphopsia. So we take into factor all the subjective and objective measures that we have, and then determine if treatment is needed, and then how long treatment can potentially be extended to. And so that's a gradual project and a process by which we come to a determined amount of time between injections. So initially, folks are recommended to have injections once a month. And then after we know that things are, the eye and the macular degeneration is under better control, then we start to extend out the treatment. So we call that a treat and extend strategy. And pardon me, once we've extended out to about 3 months between treatment, which can certainly be feasible, then we determine whether or not treatment can be just withheld, and we watch closely to see if there's recurrence of active disease activity.
And when you say active disease activity, you're looking for neovascularization and fluid. Is there a visual acuity point at which you say, okay, I'm not going to bother to monitor this patient any longer because visual performance can't be stabilized or improved?
So, and that is on an individual basis also. You know, some patients, if we think that there's no vision to be recovered and we've tried everything we can and they're at an end stage, then we may say, yes, there's probably not much more we can do, in which case there's maybe no reason to monitor. If there is any vision to preserve, which is often the case, most people, even at 2100, can have useful vision. Even if the central vision is significantly declined, there can still be useful vision. So if we think that there's still some vision to maintain or not lose, then we will continue monitoring, whether it's every 3 months, every 4 months, every 6 months, to look for recurrence of neovascular activity. And yes, that's primarily what we're looking for. And in folks who have had history of hemorrhage, then there's more of a need to monitor, because withholding treatment, the likelihood of having massive hemorrhage by not treating is there. And I've seen that happen before, where people themselves elect not to continue treatment. They say, I don't want to get any more injections. I don't think it's helping. And we have a long discussion as to, any risks or benefits of doing so. And if they decide not to, then there's a risk that, of course, there could be a recurrence. And we've seen that often people do have large recurrences in the form of a large hemorrhage, subretinal hemorrhage, which can be then more devastating to the vision. And unfortunately, the pandemic was a time where we tested this unexpectedly, because a lot of people didn't come in on their regular intervals at the beginning of the pandemic because they were scared to. And then when they came in 6 months later, we saw that there was a big change in their disease activities.
So while we're on the subject of pandemic, and some of the questions that I asked you have come from the audience, so I hope that satisfies those folks who are out there asking those questions. But with regard to the pandemic, as you mentioned, it was quite disruptive. have you employed any means to foster adherence to follow-up visits?
So initially, we certainly called and reached out to our patients and reminded them that they had their appointments, and that obviously the clinic were taking all measures and precautions to be safe, and we were limiting the number of people into the clinic, and obviously cleaning surfaces and equipment, and everyone was following mask and distance protocols. And so we called everyone just to say, you can still come in for your appointments, get your treatments, because there is a risk you could lose vision if you don't adhere to your treatment interval. And so there was, we saw it both ways. There were certainly people who did continue to get their treatments as prescribed, and others, as I mentioned, who postponed or waited because they were of their fear, and ended up having some. We definitely saw plenty of negative outcomes as a result of that.
Yeah, that's always unfortunate. But in the case of when you're essentially at the end of your rope with regard to treatment, in terms of anatomical, is there a specific point at which you would recommend low vision services for patients? And again, this is an audience question.
Sure. I actually bring up low vision at it could be at any point during their treatment, because I mean, so to me, what macular degeneration, or what we call neovascular AMD nowadays, is not a temporary thing. For most people, it's a chronic condition, and it's always going to be there to some extent. So if there's some vision loss, and often along with that, there's some atrophy. Also, geographic atrophy is often concurrent with or a later stage result of neovascular AMD. Before we had treatment for neovascular AMD, we inevitably just saw disciform scars and fibrosis. But now that we can control neovascular activity, we see what the sort of end pathway for macular degeneration is in general, and that the other pathway is atrophy. And so even wet AMD patients end up having atrophy and can have significant vision loss from the atrophy component, even if their neovascular activity is under control. So there are many points at which patients may be introduced into the low vision clinics, because even at even with a vision of 20/50 or 20/60, if there's atrophy, they have paracentral scotomas, they just have trouble with all their daily activities, then we'll bring up the option of visiting the low vision clinic to see if there is anything that can potentially help them.
I want to go back to one thing. You talked about patients who require quite extensive or chronic treatment over quite some period of time. The literature seems to suggest that there's very little adverse systemic effects from the intraocular injections. Have you encountered any of those? Is that something that's frequent in your particular experience?
I actually no, and I think that the literature speaks correctly from, and speaking from experience, from my experience, we rarely, if ever, see any systemic adverse events from giving injections. There was a lot of concern initially in our first, 5 to 10 years of anti-VEGF therapy, that there could be slightly higher risk of thromboembolic events with stroke and heart attack, et cetera, with anti-VEGF therapy. And certainly that's the case when it's used in high doses for cancer treatment on a systemic basis. But in general, we think that the dose and the amount that enters into the systemic circulation from an intravitreal injection is such a small amount that it really has very small chance or little possibility of actually contributing to any systemic thromboembolic events. If someone's had a recent heart attack or a stroke, certainly we bring it up as a listed concern, and give the patients the option to either delay the treatment or use something else as treatment in the interim. But most folks think that the risk, they don't feel it as a big enough risk that they would stop the treatment for the eye. So that was really the only initial concern systemically that we kind of worried about, but even that has sort of fallen into the background.
With the waterfront of agents that are available, what is it that influences your decision or your recommendation for any particular patient? And I realize there can probably be a multiple of answers for this depending on the patient. So maybe if you could give us a couple of scenarios there, that would be great.
Sure. You know, the great thing is that all the anti-VEGF agents actually do work, and you know, you can compare them and try to say one is better than the other. In the end, they all work. And yes, maybe one does have a slight advantage over the other. So in general, anti-VEGF therapy, if we don't have a choice of agents, in the end, it doesn't really matter. Unfortunately, in today's world, often our decisions are guided by insurance and coverage. And so we have to adhere to what the insurance companies will approve for treatment. That being said, you know, there aren't any specific features in macular degeneration that make me decide necessarily one agent over the other. If we're talking about other conditions such as vein occlusion or diabetic macular edema, more sort of vascular retinal diseases, I myself, from experience, would give a slight nudge to Eylea over the other agents as working slightly better in the case of vascular retinal disease. But in macular degeneration, I don't think there's really any large difference. So quite honestly, it comes down to what the insurance approves and what's available to the patient. So.
Okay, if we can go back to Mr. Gamble for just a minute. Before his first injection, was the scenario of the injection and what he should be expecting and so forth, did that come from you, and would you prefer that, or would you rather the patient come with some sort of a foundation from the referring optometrist about what to expect with regard to the injection?
You know, I don't have a preference necessarily. I think it's nice that when they know that they're familiar with the fact that the treatment is getting an injection in the eye, and they'll often, you know, do their own research or have their children or grandchildren do the Google search for them. But it is nice that they kind of say, oh yeah, my optometrist told me that I would be getting injections for this. So in a sense that they already have some anticipation or preparation. That being said, I leave it up to the comfort level of the referring doctors, because if they feel comfortable talking about the treatment, then certainly I encourage it. But if you're unfamiliar with the process and the type of treatment and the goals of the treatment, then maybe just leave that to the referred physician, to whomever you refer the patient to. So I don't necessarily have a preference, but I will say it does put I think the patients at a little more ease when they come in knowing what they expect. Because if I have to tell them they're getting an injection, they've never heard that before, then they do take that a little bit as more of a shock. So.
Okay. It seems to be pretty consistent with my experience with retina specialists as well. Going back to Mr. Gamble again, he's really someone who I think is a great example here, and certainly a keystone part of this program. So let me again thank you for bringing him along, and appreciate his willingness to participate. But is he pseudophakic?
He is pseudophakic, yes.
What about a patient who is, let's say, a 68-year-old with some small drusen and minimal cataract, but visually disabling cataract or visually impairing cataract? Is that someone in whom you would be averse to recommending cataract surgery, or would you green light that patient?
So obviously that's a discussion between all the practitioners involved, the optometrist, the cataract surgeon, and the retina specialist. But I don't necessarily discourage it if it's a if it's a visually significant cataract, because at 68, presumably, if nothing adverse happens in that patient's life, they have a long life to live ahead of them, so that they may be around for another 10 to 20 years, and or more even nowadays, so 40 years potentially. And if they do have that kind of longevity or life to expect, and that cataract is only going to get worse, at some point it's going to have to be done. And so I don't necessarily discourage it if it is actually visually significant.
Okay. And one other thing that Mr. Gamble mentioned was injections at both eyes. Under what scenario might you consider the bilateral injection?
So that's I think at the discretion of the retina physician. There are many folks who do bilateral injections. I personally don't, just more for safety reasons, and I think he's maybe a little bit of an anomaly, because I think, other than the inconvenience of having to come for multiple visits, I think most people don't want to get injections in both eyes, because then they don't have the other eye to function with while the injected eye temporarily recovers. So and so I think that that's maybe a little bit of an anomaly, but again, there are plenty of folks who feel comfortable doing bilateral injections. I personally just prefer not to. In certain situations, however, I will. If, say, there's someone who is it's very difficult for them to come into the clinic. Say they come from a skilled nursing facility, and they're wheelchair bound, and I'm maybe even unable to communicate. So there are some patients who, just because of their either mental or physical capacity, will do both eyes at the same time, just so they don't have to be burdened with repeated visits to the clinic.
One of the questions from the audience has to do with longevity in patients with wet age-related macular degeneration. And clearly, it's a multifactorial disease, so there might be a lot of extraneous factors that are entering into the patient's risk, not only ocularly, but systemically. And the question is, just from an observational standpoint, have you noticed that patients with age-related macular degeneration have a shorter lifespan, or don't enjoy as long a lifespan as patients without?
I don't necessarily think that's the case. So, age-related macular degeneration, of course, our number one risk factor here is age, and so the majority of my patients are above 70, and then often we have plenty of patients who are well over, well into their 80s and 90s, and I think many of them continue to live thriving lives, and often the vision is not a limitation for them, or having to get treatments is not a limitation for them. Certainly, there can be plenty of other comorbidities that come up along the way, and we see patients as they suffer and battle through other illnesses, including cancer and whatnot. So I don't think it changes their lives that dramatically.
So one of the other questions that came up here has to do with patient expectations. Mr. Gamble seems to be quite sanguine and satisfied with his current situation, and seems to have plans even going forward if he does lose further vision and is not at a level that's safe or legal to drive. What generally do you see as patient expectations with regard to their vision loss? Because in a low vision paradigm, I've had mixed experiences. I had one guy who was ready to punch me out because I told him that there was nothing we could do to improve his vision, and he wasn't going to be able to drive. And I've had other patients who kind of embrace their situation, understand it, and want to go forward with whatever can be done for them, and make the most of their lemons, let's say.
Yeah, I think I agree. There's probably a mixed bag of perspectives on this, and I think fortunately the majority fall into the latter category that you were describing, and are willing to do whatever it takes, try whatever it is, go through whatever evaluation it is. So, if I suggest going to the local optometry university to the low vision clinic, they say, oh yeah, that's great. I want to see if there's anything that can help. Understanding that there's a possibility that there may not be anything that could help, and I think we have to sort of set that expectation that you're trying to do whatever you can to adapt to your situation, and after a certain point there may really be nothing. And yeah, there are folks who I think initially have that reaction as to sort of a denial type of reaction. They don't accept the fact that their vision is compromised or they're having difficulty with their vision. But then ultimately over time, I think they do come to acceptance. So, but that can take time sometimes. So.
And one of the things that we talked about earlier was the elevation in intraocular pressure. Is there a particular go-to drop that you use? Do you prescribe that? How frequently do you follow those patients up? Just what's your general routine for patients who do show a spike or a rise in their IOP post-injection?
Sure. So if it's someone who it was chronically going to have IOP rise, and we think it's a chronic issue, then initially we'll start with something. I try to avoid prostaglandin analogs just because potential side effects, macular edema, et cetera. We don't want to confound the retina situation. So I often start with a combination such as Combigan that has 2 agents, and put them on that twice a day. But if it's patients who seem to have chronic conditions and intraocular pressure is a chronic concern, then often we'll manage them in conjunction with a general ophthalmologist, a glaucoma specialist, and often the referring optometrist that may be comfortable with glaucoma management. So it just depends on the situation, but if they don't have frequent contact with another practitioner, then often we'll just start them on a combination drop such as Combigan to begin with.
Okay. And one of the questions from the audience reminds me of one of my favorite patients in Birmingham. I started seeing this patient because he was complaining that on the golf course, he couldn't see where his T-ball landed. And we all had a little laugh over, okay, Bill, you have to quit hitting it so far. But he developed what to me is a Hall of Fame case of geographic atrophy. It involved the entire posterior pole, arcade to arcade, both eyes. He used to enjoy reading. We used to share books. We used to exchange books. He went to books on tape. And he really did okay over the course of probably three decades of follow-up, but he never developed wet AMD. And one of the things that I think it's Emily Chu has suggested is that there's some bifurcation in the pathway, that not everybody with dry becomes wet. And if we can sort out which patients are going to maintain a course to wet, we have a treatment recommendation or a paradigm for them. And others who may develop along the geographic atrophy path, and we may, going forward, have some opportunities to treat those patients and perhaps stabilize vision. Any comments on that bifurcation there, and then what you're familiar with as to potential treatments for geographic atrophy?
So I think that's probably true that the majority that have severe end-stage geographic atrophy infrequently will progress to wet. And I don't think we fully understand where that bifurcation occurs or why that mechanism is as it is. But I've certainly seen patients with advanced atrophic macular degeneration that end up developing choroidal neovascularization. So it's not unheard of. Often it's not visually significant, because if there's hemorrhage or neovascularization in the area of atrophy, then they're not going to notice that. So in the end, it may not have a significant impact on the vision. And so we have to have that discussion with the patient at whether it's indicated to treat or just to watch in that case. And depends on the situation, the amount of hemorrhage, the activity of the choroidal neovascularization, how much vision there is left, and the location of the choroidal neovascularization, whether it's adjacent to healthy retina or if it's in the middle of the geographic atrophy. So all those things sort of influence the decision as to treat or not. So it's not unheard of to have choroidal neovascularization in the setting of geographic atrophy, but it's infrequent, as you said. Now, and yes, if we had some way of telling who's going to end up on one side of the fence or the other, then that's one of the crystal balls that we hope to have, but currently we don't. So looking forward, treatment for geographic atrophy, there are several treatments in the pipelines. And a few years ago, we were actually very hopeful that there was an agent called lampalizumab from Genentech that was in phase 3 trials. And we all had high hopes that that would be the first approved treatment for dry macular degeneration. But unfortunately, it didn't. The data from phase 3 didn't pan out to show significance. And so that one did not get approved for use. So that being said, there are other agents currently going through clinical trials. We're involved in a few of those currently, and a lot of them are looking at different pathway parts of the complement pathway, and so we know that complement has a significant role in the progression to geographic atrophy, and so some of the agents that are being tested have roles in the complement pathway. So and those would there's a few that are intravitreal injections. There's one that's systemic or given as an injection sub-Q. There's also potentially surgical treatment. There's a company that called Regenerative Patch Technologies that has a implantable RPE layer underneath the retina, and it's surgically implanted to replace areas of geographic atrophy with potentially healthy RPE photoreceptors. So that's also in early phase clinical trials. Along with that, stem cell treatment in other forms and gene therapy in other forms are also being looked at. So there are many sort of developments in the pipelines. A couple of the agents will actually be going into phase 3 trials. So we're getting closer to hopefully another possible player in this game, but we still have a few years to go, I think. But the outlook is promising that something could come up in the next few years.
While we're on the subject of regeneration, one of the questions from the audience is asking for a comment on retinal rejuvenation therapy in AMD. And is this perhaps something that was tried years ago where it's plasma pheresis? There was no specificity beyond the question about retinal rejuvenation from the audience.
I think if we're talking about somehow rejuvenating the retina, then it could be done via gene therapy or stem cell treatment. Outside of that, I don't know of any other modalities of treatment that can actually regenerate retinal cells. They have tried retinal transplant. So you take a peripheral area of retina that's healthy, cut it from the peripheral area, and then move it to the central area over the macula, and see if those cells will restore some of the macular function. So that's the retinal transplant surgery. None of those things are sort of in the mainstream as of yet. So I'm not sure specifically what else rejuvenation may be referring to, but outside of that, there's not much that we have.
You mentioned that you would tend to avoid latanoprost for IOP reduction in patients post injection. One of the questions from the audience kind of relates to that. And would bimatoprost in the form of Latisse be discouraged in someone with age-related macular degeneration? Just in general, not necessarily, I guess, as a as something to be abandoned in the immediate post-operative period?
Sure. I think overall, no, I don't think there's any real objection to that. I would caution though, if in the immediate setting of the injection, I would say within the 48 hours after the injection, we would obviously advise people to avoid manipulation of the eyelashes or the eyelid surface, because that can certainly mobilize or force bacteria into places where they shouldn't be. And so we certainly want to avoid any manipulation that could pose a risk for endophthalmitis if after an injection is given. But overall, I don't think that sort of on a long-term basis, there's any real contraindication or downside to using Latisse.
And I should probably circle back. I mentioned that your training took you across the country and you had kind of made your way back to the West Coast, but I didn't mention that you're with Orange County Retina, and that's something that Mr. Gamble did refer to. So for the sake of the audience, that should complete that circle. So apologies for that. But someone in the audience, Dr. Ravad, would want to know about a 2RT laser, something I'm not familiar with. Is that something you're familiar with?
2RT laser. No, I'm not necessarily familiar with that.
Capital R, capital T. And then another question, photobiomodulation for age-related macular degeneration.
So that's not something that we sort of use in our practice. So I can't necessarily speak to any benefits or adverse events of using that modality, but yeah, we don't use that.
Okay, and another question from the audience, and this is something that Dr. Gerson and I have been panelists on for different companies, and the dust seems to have settled around genetic testing. Is there a genetic test that you recommend? Is there a strategy that you find useful with regard to genetic testing for age-related macular degeneration, if you were going to recommend supplements for patients?
Sure. I think the Academy stance, the American Academy of Ophthalmology, the stance is still that routine genetic testing for macular degeneration is not recommended. And so we don't necessarily have all the answers, and we don't know what the role of genetic testing is going to be in the future, and in several areas. One, as far as risk of progression to more of the advanced stage of macular degeneration, we can't necessarily stratify risk at this point based on genetic profile. And then number two, in terms of nutritional supplementation or treatments, what is most appropriate based on the genetic profile. So I think there's still a lot of questions to be answered. We're not hearing the debates on the podium as much anymore, but I don't think the debate is entirely over, and I think there just needs to be more data. So I don't necessarily recommend routine genetic testing because, again, we would want to do so if it were going to offer us some validated information or data that could help us in the management of the patient. But again, for the Academy's recommendation, that none of the data is validated, and we can't make any specific recommendations based on the genetic testing.
And that seems to be, like I said, the dust has settled on that, and the most recent statistical evaluation seems to kind of reaffirm the AREDS data. And then another question from the audience. Let me get to my list here. You've conducted and participated in a number of clinical trials, and one of the questions is there a website or organization to contact to find out about clinical trials? And the NEI has just introduced a portal for age-related macular degeneration. But how would one become a participant in a clinical trial?
So if you go to the FDA site. They have the clinicaltrials.gov. They have their all the clinical trials that are ongoing listed on that, and you can search by type of disease or location, and you can see what trials are currently available, and then it will list the if there's an active trial that's enrolling, it will list the participants or the sites that are recruiting for that clinical trial, and so that's probably the best way. If you are in an area where there is a large retina practice or an academic retina practice, you may want to contact them to see what trials they have going on, because many of the large practice retina groups are participants in clinical trials, or at the university academic center. They would be good resources for finding out what's available locally. And then if they're participants, then obviously they can tell you how to get involved or get enrolled in a clinical trial. But if you're just finding on the clinicaltrials.gov site, then you would just contact the primary site, the primary investigator site, and they would be able to guide you in terms of where you might be able to get enrolled if it is something that would be feasible for you or your patient.
And I'm sorry, at the beginning of that question, my preface, I said it was the National Eye Institute. It's the National Institutes of Health. So if you were to Google National Institutes of Health and AMD portal, you would find some information on age-related macular degeneration and perhaps another pathway to clinical trials. We mentioned geographic atrophy earlier, and I talked about my patient who had what I think is the worst case ever, but one of the people in the audience, excuse me, has described a patient very, very similar to that. And then still another questioner in the audience asks, is there any insight that you might have on Zimura for geographic atrophy?
I can't necessarily speak to that, even if I did, because it's some of that information may be protected, but again, there are several agents, including Zimura, that are going through the clinical trials process, and data has to be collected and analyzed before any sort of final conclusions can be made as to its safety and efficacy. But it's promising. I will say it's promising. And we had another part to the question?
No. That was it. But if we can circle back to perhaps the patient with glaucoma and age-related macular degeneration who is on latanoprost, what should be the discontinuation before and after the injection for that particular patient?
So I generally say if they're on glaucoma therapy, that if they want to, they can actually continue their drops as they normally do. If they felt like the eye was a little irritated or uncomfortable, then they could skip that day's dose and then resume the next day. As far as effects on effects on the macula, if they've been on it and it's helped to control their glaucoma, I don't necessarily recommend changing it, and we just treat the macular degeneration as we would otherwise. But I certainly don't start people on it de novo if they've never been on any antihypertensives as the first agent. But if they've been on it previously for glaucoma and it's helping to control their glaucoma, then I won't necessarily recommend changing their treatment strategy just because of macular degeneration.
So maybe we can finish up with a couple of questions regarding early diagnosis. I was involved, as I mentioned, and I don't know if you were on the call yet, the dark adaptation instrument that's commercially available was developed by one of my former colleagues at UAB, Greg Jackson. And I was part of the initial process of that. And I was absolutely amazed at how well it differentiated patients who had early AMD. We were blinded to their fundus findings, but how strict a demarcation impaired dark adaptation made for patients with early AMD. Is that a diagnostic test that you use and are familiar with?
I am familiar with it. However, we don't use it sort of on a regular basis because the majority of the patients we're taking care of are generally in their later stages or needing treatment, and so as the utility in that setting obviously is probably less so, but I think there certainly is some utility to it and validity to that, and invariably, after blurred vision, the next complaint that patients have is trouble with low light settings or needing extra lighting. So and that's usually at the later stages. So certainly if that can be detected at an earlier stage, then that can have some applicable role in our practice.
Okay, and then so that's a little bit of a difference just between your specialty practice and what maybe an optometrist would
Correct.
be seeing. And I'm scrolling through because there was a question that caught my eye. Oh, yes, it was with regard to early diagnosis. One of the things that Jeff mentioned for early diagnosis was the foresee home monitoring, and there's home monitoring for intraocular pressure, for example. Is that something that you think in the setting of a patient with wet AMD might be valuable, or more valuable in the setting like dark adaptation for patients before they need to see you?
I think it could have applicability in either setting. I think more so before they get to me. That's certainly a very useful area if there's just some pre-neovascular disease sort of suspicion, and then there's a change on at-home monitoring that could prompt an urgent visit that could lead to the diagnosis of neovascular AMD. Then sure, that I certainly think that's a very useful place for that. In active disease, it can probably still be useful. Our practice, we don't necessarily use it, but there certainly is some potential uses for it, and most patients are still going to be monitored on a regular basis because, like I said, from our viewpoint, wet AMD is a chronic condition, and there's always a chance that it can show up again. And so at this point, we still like to at least do a complete physical exam on a regular basis just to see what the level of disease activity is. And so it's not as useful in that setting, but like you said, I think at the point where before they get to the specialist, then I can see how there's a useful role there.
I had a patient that I shared who we showed the color fundus photograph as well as the OCT. And the OCT showed some very distinct irregularities of the retinal pigment epithelium, and other cuts of that patient's OCT showed the evidence of invasion demonstrating choroidal neovascularization. And one of the questions from the audience says, how do you tell the difference between drusen and choroidal neovascularization that needs treatment on OCT? And if I remember correctly, Margaret Starks, many years ago, a histopathologist, I think from Australia, suggested that every large druse actually harbors a tuft of neovascularization. But to go beyond that, do you see any value in OCT angiography for your management strategy, for your diagnostic, or for your management decision making for patients with choroidal neovascularization?
So yeah, I think if there's a very, very large druse, and we'll refer to it as a drusenoid PED, because at that point, if there's a PED, then we're worried about neovascularization in that PED, and so determining whether there is true neovascularization or not, there are several things that can potentially help us. I don't think you can rely just on OCT for that. I don't think that's sufficient for making the determination. OCT angiography can be helpful for that, because you can actually potentially see the net on certain slices of the OCT angiography. We have that in one of our offices, and we do use it. However, it's not readily available in all of our clinics, so it's not the go-to. I still think there's a very useful and valid role for fluorescein angiography, because that can certainly help to distinguish just a PED that's pooling fluid versus a true neovascularization, where there's active leakage out of the blood vessels causing that buildup in PED. So I think there's still a role for that. And so if there's a large pigment epithelial detachment that we're worried about neovascularization, I'll certainly recommend fluorescein angiography to determine whether or not treatment would be needed.
Okay, and then one final question, and I guess this is like the grand fanfare of a fireworks display. Very, very short question. Do you recommend vitamins? And I'll be happy to start with my recommendation, which is personal, and that is that I think anybody at risk should probably be taking a carotenoid. There's some very strong evidence for omega-3s also, although that is quite controversial, as well as some sort of, or some concoction of some cocktail, perhaps another C there, of antioxidant vitamins. So Dr. Rathod, if you'd share your perspective on that, I would appreciate it, and we can conclude.
I recommend AREDS2 supplementation for, and I buy the book Intermediate Advanced Dry AMD or Advanced AMD in one eye. Then I certainly recommend the AREDS2 formula, just as the literature suggests. So obviously there's so many different products and different variations, but my main recommendation is that the patient should adhere to an AREDS2 formula, which includes the omega-3s, as you mentioned, which I agree there's probably some benefit to it, even though the data doesn't necessarily all support it. And then, of course, the antioxidants and the carotenoids, as you mentioned also. So that's my recommendation.
Okay, well, I can tell you this, Dr. Rathod, it's been a great pleasure to work with you and to meet you virtually, even though we're probably several thousand miles apart.
Likewise.
I hope I hope the audience has benefited from this. I'm going to turn the program back to Stuart Autry.
Thank you, gentlemen. Dr. Rathod and Dr. Sims, thank you both. I think tonight's content was fantastic. The audience response has been overwhelming and extremely positive. I'd like to thank the Macular Degeneration Association for making tonight possible, and specifically to Nodal Vision for allowing us the educational grant to bring this content to the audience. Again, we'll be posting these hours to everyone's OE tracker on code electronically, and sending CE certificates via email to all the attendees, along with a survey to complete. Thank you again, and that concludes tonight's presentation.